Thank you, Sam. Thanks for all the work that you've done to make this happen. Thank you to Afnan from Senator Eldridge's team. And hello, everyone. Greetings. I am absolutely delighted to welcome you today to Medicare for All, Public Health Implications and Steps Forward, this wonderful panel. My name is Jo. I have the honor of representing the Hampshire-Franklin-Worcester District in the Massachusetts State Senate. And I'm also currently chairing the Senate's COVID-19 working group, in addition to being the Senate co-chair of the Joint Committee on Public Health. Before we start, I want to take a moment to thank the members of the Medicare for All Legislative Caucus, particularly my three co-chairs, Senator Jamie Eldridge and Representatives Lindsay Sabadosa and Tammy Gouveia. I also want to thank our partners, the Western Mass Medicare for All, a great group of folks right in my district, MassCare and Healthcare Now. Today's program reflects the hard work of all of these partners, all of these people, and we thank them all for going to bat for Medicare for All, for universal coverage, and for all that they do. I also want to mention that today's program is the first in a two-part series on this issue of Medicare for All and public health. We will continue the discussion on Tuesday, October 13th at 4 p.m. In a discussion which will include Representative and now Doctor, congratulations, Tammy Gouveia, Dr. Catherine Delory, President of the Women's Health Institute, and Dimple Rana, Director of the Health Community Initiative for the City of Revere. So please be sure to join in 4 weeks from now. We are tremendously fortunate, turning to today, to have three esteemed panelists leading our discussion and going deep on the issue of Medicare for All and public health. Today's conversation on universally affordable and accessible healthcare, single payer, within a public health context, was an important one to have prior to COVID-19. In truth, it's been an important conversation, a necessary conversation to have for generations. But now, amid the pandemic, whose stranglehold on our communities has exposed the gross and groaning inequities along race, ethnicity, class lines, this conversation takes on an even greater and more urgent importance. We'll start by hearing from Sameen Ansari and Olivia Sonderman, both of whom recently graduated from Harvard with Masters in Public Health. They've focused their research in the last year on the public health implications for universal government-sponsored single-payer healthcare in Massachusetts. They looked at academic literature and analyzed Massachusetts data in light of the research. Sameen and Olivia will then introduce their acclaimed professor, Dr. William Hsiao. After Dr. Hsiao, we'll open it up to questions from participants. For those tuning in via Twitter and Facebook, please use the following hashtag. This is hashtag M4A is public health. So again, hashtag M4A, the number 4, M4A is public health, to ask a question or make a comment. If you'd prefer, please add your questions or comments below the live feed in Facebook. And I know that many people are sharing this Facebook feed, so hopefully we'll get lots of questions and comments. Let me just gush for a moment about Sameen and Olivia, who are currently completing their MDs and were MPH students while they were also holding down public health fellowships as part of our team, the public health team in the state Senate. They are tenacious, passionate, buoyant advocates for healthcare equity, rigorous in their own research and scholarship, and endless, and absolutely endless in their goodwill. Sameen is currently a fourth-year medical student at Oakland University, William Beaumont School of Medicine. As I mentioned, she recently completed an MPH in health policy at Harvard. In medical school, Sameen has been working with underserved populations and helped establish health literacy training for patients experiencing homelessness. In order to better advocate for her patients, Sameen joined the Michigan State Medical Society and served on the board of directors for 2 years. I don't actually know when she sleeps. In the future, Sameen hopes to be a family physician who is directly involved in policymaking process and continues to make health more equitable. Like Sameen, Olivia recently completed her MPH in health policy at Harvard She is a medical student at the University of Nebraska Medical Center. Also, I don't know when Olivia sleeps. At UNMC, she served as co-president of the Student Delegates, a grassroots interprofessional student organization that educates students on legislation and advocacy at a local and state and federal level. She has been involved in the Nebraska Medical Association and American Medical Association throughout her medical career, experiences which informed her decision to seek a public health degree. She is interested in creating solutions for both local and global health disparities. And while we focused on today's panel, again, I want to make sure that folks know that October 13th, we're going to revisit this question about Medicare for all and public health. And again, please, as I turn it over to Sameen and Olivia, please also let me extend my own thanks, and I know they will warmly welcome Dr. Hsiao for his expertise, his lifetime of advocacy and work around single-payer, universally affordable and accessible care. It is an honor to have you with us, sir. And now over to the tireless Sameen and Olivia.
Thank you, Senator Comerford, for your kind remarks. And of course, thank you to everyone who's joining us today. Single payer raises strong emotions, whether you support single payer or oppose it. But that is the importance of today's presentation, moving away from the political rhetoric surrounding single payer and instead focusing on the data in the realm of public health. And as Senator Comerford mentioned, as the co-chair for the Joint Committee on Public Health in the Massachusetts Legislature, she has a vested interest in the public health of residents throughout Massachusetts. So to begin, Sameen and I wanted to offer you an overview of our steps today. So first, we'll begin with a background. So defining what is public health, or what entails a single-payer healthcare system, and what's our current health status here in Massachusetts. In step 2, we'll discuss our findings in the literature in the realm of system transformation and also in chronic disease, 2 subdomains of public health. And lastly, we'd like to leave you with some conclusions from the research that we conducted. So what is public health? Public health is dealing with whole populations with a focus on preventing disease. So this is different from, say, the care that Sameen and I give to patients as medical students, which is individualized and often focuses on treating disease as it happens. So when you think about public health, think about populations and think about prevention. Traditionally, in the realm of public health, we have 3 outcome measures: mortality, looking at death; morbidity, looking at disease; and disability, looking at functional limitations due to disease. So one of the challenges, as you might imagine from looking at public health, is it's quite broad, encompassing things such as environmental quality, emergency preparedness, and disease surveillance. So at times, it can be hard to completely capture all of the public health outcomes that we would like to look at. Particularly for the purpose of this presentation, Sameen and I focused on public health system transformation and chronic disease as 2 focus areas within public health that Massachusetts has expressed an interest in improving in the state. And as you can see listed on the slide in the image, there are many domains of public health, but for the purpose of the presentation, public health system transformation and chronic disease will be what our focus is.
And before we talk about our findings, we think it's important to give you a snapshot of where we are at currently in terms of our healthcare coverage, both in the United States and in Massachusetts, so that once you have an understanding of where we currently are, you can get a better picture of where we can perhaps go with a single-payer healthcare system. So currently, just an overview of the US, our healthcare system actually ranks in last place, 11th out of all the developed countries, so pretty abysmal. In terms of Massachusetts specifically, we've been heralded as one of the vanguards with a great insurance rate at 97.2%. But if we get too caught up in that number, we can forget the disparities that it masks. There's actually a 2.8% of people in Massachusetts that currently have absolutely no healthcare coverage whatsoever. And even for those who have insurance, out of that 97%, affordability is still a massive issue for almost half of those who live in Massachusetts. And an issue we have to think about with affordability is underinsurance. people who have insurance, but they aren't able to access care because they can't afford it.
In the realm of chronic disease, Massachusetts also has room for improvement. So another term in the public health world is amenable mortality, which refers to deaths that may be prevented by timely and effective healthcare. So as you can see in this graphic from the 2017 Massachusetts State Health Assessment, I want you to focus on two aspects. One, that there's significant amenable mortality across populations in Massachusetts, as can be shown on the rates per 100,000 population. And secondly, there's significant disparity amongst racial categories in the state. And as we know, and as Senator Comerford alluded to, COVID-19 has only highlighted these disparities in preventable conditions that exist in Massachusetts.
So an important point to keep in mind, as we've seen these past two slides in terms of Massachusetts' overall health system and in terms of our chronic conditions, is that there are massive coverage gaps that still exist in Massachusetts that are negatively impacting our public health, and they absolutely need to be addressed. And one important definition for us to highlight before we move into our findings is, what is a single payer system and how does that compare to our current system in Massachusetts? So if you look at a single payer healthcare system like Canada, an important consideration to think about is the ethical foundation. So in Canada, healthcare is a universal right, versus in our current system in Massachusetts, healthcare is seen more as a commodity, something that can be bought and sold. The next aspect is eligibility and equity. Since healthcare is considered a universal right in Canada, that means that, or a universal right in a single payer system rather, that means that you have access to that care by virtue of you residing there. So if we were to have a single payer healthcare system in Massachusetts, any resident would be able to access that, regardless of their ability to pay. Currently in Massachusetts, however, that is restricted, your access to healthcare coverage is restricted by your ability to pay. It's also important to think about benefits. When you're designing a single payer healthcare system, you can have a wide variety of benefits in that system. And that's the role of lawmakers and legislators to come together and decide what's important to include, because what you include is going to be given equitably to everyone in that system. Versus, once again, currently in our Massachusetts system, your ability to access certain benefits depends on your ability, not surprisingly, to pay. Lastly, funding. So we're not specifically focusing on funding in our report, but it's important from a definition perspective to understand how funding differs in single payer versus our Massachusetts system. So in a single payer healthcare system, all of the funds are pooled together to a central government source, and then those funds are allocated to individuals based on their need. Versus in our current system in Massachusetts, the funds that individuals pay to their insurer are allocated to individuals based on their ability to pay. And next, we're going to focus on our findings. So what does the literature say on how increasing coverage impacts public health? And like we've mentioned, we're going to focus on two broad domains, which is system transformation and also chronic disease. In terms of system transformation, if we were to have a universal, a single payer healthcare system, or we were to increase access to coverage, it would obviously improve access, but also improve equity. And a way to think about it is people who are uninsured or underinsured, meaning people who have access to insurance, but they don't have access to the care they need because they can't pay for it. Those two groups actually access healthcare less than those who are fully insured. And a point that highlights this is looking back to the 2006 Massachusetts healthcare reform. Overall, when people got more access to health, this had an overall positive effect on health, and people were able to access preventive care more. Also, if you transform into a single payer healthcare system, you can maintain coverage without any gaps because there isn't a need to re-enroll in coverage due to administrative hurdles. And a point that illustrates this in Massachusetts is we close 34,000 mass health cases per month, 11,000 of which are just re-enrolled in 90 days. And this means that there are individuals who might have a completely unnecessary gap in their healthcare coverage because of an administrative hurdle. And another thing that can contribute is if you change in your employment, you change an employer, you also get a gap in your coverage. System transformation can also, or a single payer healthcare system also can have an important role by unifying all the different electronic healthcare records. So the current system as it stands is every hospital might have a different healthcare system, and those systems aren't necessarily communicating with each other. So as a medical student, if I have a patient who has records in another hospital and has had testing done in a previous hospital and has history from a previous hospital, I might not have access to any of it, which might lead me to increase testing and also make a decision about their care without the full picture. So these are things that a single payer system can most definitely address.
Next, we wanted to focus on the realm of chronic disease as one of our subdomains of public health. So as I alluded to before, mortality is one of our traditional measures of public health outcomes. So in the literature, we found that single-payer healthcare systems show improvements in lives saved. So specifically, a 2020 article from The Lancet showed that if the United States were to implement a Medicare for all system, that 68,000 lives would be saved annually. Now, there is some concern about the correctness of that exact number, but overall studies show a positive influence, so a decrease in mortality in single-payer healthcare systems. And as we saw in Massachusetts in the previous graphic, there is room for improvement in a minimal mortality in the state. Next, single-payer healthcare systems show an improvement in primary care. So in studies that looked at cities with varying healthcare systems, single-payer healthcare systems had lower preventable hospitalizations than those systems who had other types of healthcare. And significantly, across healthcare systems, minority groups as well as lower socioeconomic groups had higher rates of preventable hospitalizations, which ties into the equity piece that single-payer system can help to address. And lastly, mental health is an important issue in the state of Massachusetts. And what has been shown is that having a single-payer system can allow integration of mental health care into what is seen as traditional medical care. And really, it is that transition from an old system to a new system that allows for perhaps a state like Massachusetts to really refocus its efforts in the mental health care sphere. Now, of course, as with any health system, there are challenges. And so across the literature, what Sameen and I found were three challenges that emerged most often. So first, long waiting times for non-urgent healthcare. Second, possible delays in pharmaceutical innovation. And third, the necessity to design a benefits package that offers basic health services in order to achieve public health outcomes as appropriate. So really, this is a piece that requires lawmakers to create a benefits package that does improve public health. Across these three challenges, what we also saw was that single-payer systems can design solutions to address each of these. And we were speaking with Dr. Hsiao about this, this very topic this morning.
And overall, we've seen that single payer can be a trigger word. There can be people that can be completely for it and supporting it, or people that are completely against it based on their emotional preconceptions. But it's important for us to strip all that away and focus just on public health and what people in Massachusetts need. And our research has shown that there are clear coverage gaps. There's people who don't have any insurance at all. There's people who have underinsured. They need access to care, but they just can't pay for that care. Not to mention, there is death and chronic disease that can be completely preventable by timely access to care. So our research has shown that a single payer system could have positive implications for public health in Massachusetts because of an increase in preventive health care for the entire population. But as Olivia has noted as well, the success of any healthcare system, including a single payer healthcare system, depends on lawmakers and legislators' ability to come together and develop an equitable benefits package that really addresses the needs affecting the population. And lastly, we wanted to make sure to mention that our research leaves a potential area for growth for future research, because we didn't do a full systematic review of every article out there because, you know, we're two people. But that could be definitely an area for research, as well as looking at the literature on individual states, because right now when we were looking at the state of Massachusetts, we often just had an entire country to compare, like the Taiwan or Canada. So having more research about individual state data in a single payer system would really help. And of course, looking at cost and the political implications of having such a system would also be very beneficial. And overall, this project would not be possible at all with the help of so many incredible individuals who we are truly indebted to, which unfortunately we don't have the time to individually acknowledge right now, like I would absolutely love to do. But thank you so much, and particular thanks to my amazing partner, Olivia, who this project would not be possible without.
And of course, right back at you, Sameen.
And also, we just wanted to remind everyone who may have joined in late that you can submit questions via Facebook or Twitter using the hashtag M4, which is the number 4. M4A is public health. Next, we'd like to introduce our esteemed professor, William Hsiao. And Professor Hsiao is a K.T. Lee Professor in Economics, Emeritus in the Department of Health Policy and Management and the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. He's a leading global expert for studying single-payer systems for more than 40 years. He's been actively engaged in designing health system reforms and universal health insurance for entire countries, including the USA, Taiwan, China, and the state of Vermont. And most importantly, he served as the incredible mentor for Olivia and I during our studies at Harvard and throughout this project. So now I'd like to turn it over to Professor Hsiao.
Hello, everyone. Now I'm unmuted. Thank you very much, Olivia and Simon, that you gave an excellent presentation in such a short time about what is the difference between a single payer system and the current Massachusetts health system, in terms of both the transformation and transforming the system, as well as how the chronic diseases will be treated. And you show the advantage of that, and thank you very much. What I'm going to do next is I'm going to actually cover going to one topic in depth, but trying to pose a question to the Massachusetts, the senators, and particularly Senator Jo Comerford and her colleagues, as well as the public in Massachusetts, whether you want to take some transitional steps toward a Medicare for all, a single payer system. Let me begin by just quickly summarize the advantages of the Medicare for all. Everyone already know, and as well as Olivia and Simon mentioned already, one is provide universal coverage, everyone, just based on your residency, geographical area. Second is everyone has equal insurance coverage. You have the same benefit package, not the one where Massachusetts have 97% of people covered, but there's glaring gaps in their benefits, and unequal benefits, I call it, okay? And then third is under Medicare for All is you want to ensure everyone have equal access. So it's not just insurance, but it's equal access to healthcare. Next. So those benefits of Medicare for All are well known to everyone. However, there's one part which is not mentioned very much, and it's not that well known. That's the focus of my presentation today. And I called it, it's a lamp hidden under the bush. And so I like to bring out the lights today. Medicare for All will vastly reduce the waste, the inefficiencies, and the fraud and abuses under the current system. There are numerous studies that's published since 15 years ago. All of them come up with the same average answer, and that is 30% of our health expenditures every year is wasted and or is paid out for fraudulent claims or upcoding or abuse in billings. Next. So let me elaborate those points to show you what magnitude of dollars they're involved. First of all, if there are these several projection models, credible projection models based on unbiased data. And we show that right now, doctors and hospitals, in order to deal with the multiple health insurance plans, they have to employ a large number of administrative staff. On average, every doctor has to spend 8 hours per week to deal with varied health insurance regulations because there are so many of them. Just give you a number. When I worked in Vermont, we made a study. We found every doctor had to deal with 30 different regulations from 30 different health insurance plans. And each one has also different forms you have to fill out to get paid. And that absorbs 8 to 10% of our total annual health spending. The second part is with multiple insurance plans. Now each one is trying to compete. They pay commissions to sales people. They advertise, and you just watch your television program, you can see that. And they have a sales manager, sales staff, and so forth, plus the administrative staff. Then all the employers, larger ones, have to employ one or several people just to stay on top of the variety of health insurance plans and the issues, and also advise their employees what health insurance plan they may want to enroll in. Those administrative expenses make up 6 to 10% of your total health expenditures every year. Then, this may come as a surprise to you. Fraud and abuse in billing is rampant. Close to 15 years ago, FBI investigated the Medicare program and say, close to 8% of claims paid out under Medicare is because of fraud and abuse and overcharge. And then the administration tell FBI stop doing these investigations. So we don't have more recent data. But if you read the literature published to guide physicians and hospitals how to build, they acknowledge the current fraud and abuse and overcharge is about 10% of total billing. Medicare for All with a single payer actually can wipe that out because they will have a complete medical record of how much each provider, each doctor bills the single payer plan. And so they can identify the ones who really commit fraud and abuse. They leave other providers alone. And that's what Taiwan found. They can leave roughly 85% or more of the doctors and hospitals alone, just focus their attention on roughly 10 to 15% of providers who abuse a system, including file for fraudulent claims. Then the next item, which I think most people already know, it's well documented that United States paying for the same drug that's sold to Canadians or to Europeans, we pay 2 to 3 times of the price paid by those countries. And in Massachusetts, the Attorney General has been trying to deal with monopolistic pricing, like trying to look at the different big health delivery systems like Partners, which charges the highest price. You wonder why. Well, one economic explanation is because they have monopolistic power. This can be dealt with under a single payer system by the payer negotiate with these suppliers, and because now they represent more insured people. So then let me conclude with this slide by saying that I mentioned we're wasting roughly 30% of our total health expenditures. What does that mean in Massachusetts? That comes to $18 billion in 2018. In 2018, Massachusetts spent $60 billion for healthcare. And it really put pressure on the state budget, as well as corporate budgets and the individuals. But 1/3 of that, $18 billion, really did not go for medical care, but went for administrative arrangements because the structure of our system. What does that mean for each individual in Massachusetts? That means it's $3,000 every year can be saved. If we can even save, let's say, 1/3 of that, that means we could actually give everybody a $1,000 increase in their income. That's literally what it means. Next, please. So then why don't we have single-payer system in America. Actually, as early as 1972, President Nixon privately negotiated with the House and Senate was going to, they trying to get agreement to introduce one. Because I was involved with it. But then because of really is an accident politically, they decided one of the key players dropped out. Then President Carter tried to look at this, designing a single payer system for the United States in 1978, 77, 78. So, but we did not move ahead. So we have to face the reality. There are really some serious oppositions. However, maybe those oppositions are weakening nowadays, but I want to point out what they are. One is really in America, we build our healthcare system based on the market principles, as Sameen and Olivia already pointed out. So it's your choice. You decide what you're going to spend, what you're going to buy. And that, to change the system to a single payer, you have to shift from a free choice to buy health insurance to a mandatory system. I can tell you many young people, healthy people, they say, I don't want to pay anything for health insurance. I'm not going to be sick. So you're going to have at least that group of people even rationally say, I don't want to pay, except then they don't think they're going to get old later on. The second barrier to adopting Medicare for all, it comes from providers. I'm sure you have seen data that the same provider, the hospital, for example, for bilateral x-ray, you will have 8 different charges. And those charges could differ by 3 to 5 times. Because they charge patients and the insurance companies differently depending on how much market power you have. So the uninsured people are charged the highest amount. And the hospitals and doctors do not want to actually see that advantage go away. So there's reluctance. Although we know it's wrong, but they have that advantage now, so they're reluctant to give that up. A third group is obvious to everyone, and that's the insurance companies, health insurance companies, pharmaceutical companies, and some high-priced hospitals. And you know, they all declare they are publicly, they are against any form of single-payer system, particularly Medicare for all. And those are powerful and wealthy vested interest groups. It's not so easy to overcome their opposition. Then for a state like Massachusetts, if the state wants to go over to federal, to establish a state program, then you need federal exemptions. So you can merge Medicare, Medicaid, VA, and then maybe Indian health programs into one unified system. So I just want to acknowledge to adopt Medicare for all is not that necessarily so simple. There are powerful political oppositions, entrenched institutions that may be the opposing it. Next, please. So then let me quickly take a look at mass. I'm sorry, go back to the, what's the condition in Massachusetts then? And Olivia and Sameen already point out 97% of the people are covered, but they don't have equal benefits. And Massachusetts really have some powerful monopolistic providers. And I want you not need to elaborate on that. And but meanwhile, in the western part of Massachusetts, as well as in the poor sections of the cities, there is not an adequate supply of medical services, particularly for primary care. So Massachusetts have to deal with that shortage, particularly for the low-income people, as well as for the rural residents. One good news is that Massachusetts had appointed a health policy commission, and that commission has been effective to set targets for health spending inflation every year, and then trying to make sure we meet those targets. However, I want to point out, the Health Policy Commission is not trying to deal with the fundamental flaws in our system, but remove the waste and the inefficiencies. They're only just trying to control the annual growth rate. So we in Massachusetts is still spending money inefficiently and ineffectively. Next slide. So then what would be the basic building block for Medicare for all? First of all, you have to establish a uniform benefit structure. That's for everyone. And for Massachusetts, then you might say we could do step by step to increase the benefits for those who have very poor benefits now. And also we have, as I mentioned, we have a shortage of qualified physicians and clinics, and maybe even hospitals in the rural area and in the low-income communities. So the building block for Massachusetts is to establish target programs to address the shortages of supply. But for example, later on, I will offer one possibility how to do that. Next. Certainly, Massachusetts could establish a purchasing alliance, bring together all the hospitals, and also draw in even the retail pharmaceutical stores to bargain with the pharmaceutical manufacturers and the distributors for lower prices. As I mentioned earlier, we are spending for exactly the same drug. We are spending 2 to 3 times of what Europeans pay on average. Next, please. it was mentioned earlier already by Olivia and Sameen that we could create a uniform standard electronic record system, which then can also be used as a standard claim data system. So you don't have to spend billions of dollars to train physicians and staff to learn new data systems every time they change jobs. If you look at the Mass General, you see they actually say they spend several $billions just to train their staff on how to use the electronic system because they made a change. We can remove that kind of duplication and redundancy. And then next is we can also establish one uniform claim payment procedure. So hospitals and doctors only have to learn there's one set of rules applied to them for them how to record the patient's condition as well as what services they render to get payment. So they don't have to learn that right now, like I said, could be up to 30 different set of rules. Next. So with these building blocks that have to be put in place for Massachusetts or any state that want to move to a single payer system, then I would suggest these transitional steps for Massachusetts to consider, particularly Senator Joe Comerford and her colleague, Senator Eldridge, I have met before. You have been dealing with this issue for many years. So these are the transitional steps you may want to consider. If the state budget has the funds, you can try to give subsidies to bring the benefits of those which have very low benefits up to some higher standards. And we could spend the state budget to say we're going to pay a bonus to providers like doctors or physician assistants and even pharmacists who are located in the underserved areas. Or we could establish more community health centers for the underserved areas. Next. I've already mentioned we need a unified clinical and claim data system. The good news is right now, the clinical record system is converging to two different vendors. So we're closer to actually maybe able to bring them together. But then the state could pass legislation, set steps to say all the providers should use a common electronic health record system. And then you use that system to produce a uniform claim payment system, record system. That will save, I guarantee you will save billions of dollars in Massachusetts alone. Next, please. Third is actually standardized claim payments then. You don't have to let every insurance company set their own procedures, make their own rules. And creating this work for physicians, nurses, and also they have to employ. You look at how many thousands of claim clerks every hospital employ. Look at, I'm familiar with how many they are employed by Mass General or Brigham and Women. They are literally thousands. And these people could be doing something more productive for our economy. Okay. And then while it reduce the cost of healthcare if we have one uniform standard claim procedure and rules for paying claims. Next, please. I already mentioned the state could work with all the providers who are buying the drugs to form a purchase alliance. And or you can work with all the insurance companies, because this state, besides Medicare, Medicaid, we only have roughly 5 major insurers. And I'm sure there's willingness to form a purchase alliance so they can bargain with the suppliers of drugs or supply of services. But that requires legislation. Next, please. Providers will tell you, I'm charging these high prices because it costs me so much. Medicaid underpay me. Medicare underpay me. Well, let's do evidence-based pricing. Require every hospital to have cost accounting following the standard general accounting practice and certified by public accountants on what is the cost of their services, and then make them transparent. Compare their costs to their charges. And then also you will see which hospital maybe really is inefficient, or which physicians' clinical practices or clinics is inefficient. Because in most countries or states I worked in, I found doing exactly the same service, the cost could vary 2 to 3 times in the same community. And that's what happens when DRG was developed. That's what we found too. That's what's 1981. And last, what we can do is really educate the public. The public have to understand the advantages of a single payer, and also they have to understand they will actually get more pay, income, although they may have to pay higher taxes, but meanwhile, they don't have to pay any more premiums. They don't have to pay any out-of-pocket costs and deductibles and so forth. We tried this in a very small experiment in California. When we explained to the public, and on the margin, you see up to 5% of people then change their minds and support the single payer system. So these are the transitional moves I believe Massachusetts can undertake if the senator won't take them into consideration. Thank you for your attention, and I'm willing to take some questions. I'm sure Olivia and Sameen also willing to answer questions.
Thank you so much, Professor Hsiao. Thank you, Sameen. Thank you, Olivia, for these incredibly wise words and for your research and for your work. Again, it's an honor. We're sorting through lots of comments and questions. There was one on Twitter. So we have questions coming in via Twitter and Facebook. And one was really actually just a quick recap. And I think this would go to you, Sameen and Olivia. Could you just sum up one more time the public health benefits of switching to Medicare for All, a single payer system?
Yeah, so in quick summary for the public health benefits, we can try and go to the slide as well. Olivia, if we can just switch over. So let me just give her a chance to backtrack here a bit. But overall, the main takeaway was that with the single payer system, you would improve access and equity because more people would be covered. You would have continuous coverage. There wouldn't be a need to re-enroll every single time, your employer changes or some other administrative issue happens that you need to get unenrolled and then re-enrolled. All of that means that you're having a gap in your coverage and you're not covered when you should be. And then Professor Hsiao also just talked about this as well. If you had a universal electronic healthcare record, that's just another great way to have continuity of care because the healthcare providers can all talk to each other and know what testing happened and what your overall health history is. And then Olivia also covered some other main points here for chronic disease.
Yeah, so in the realm of chronic disease, the three themes that we focused on and found in the literature were decrease in mortality in single payer healthcare systems, and improvement in primary care services, which led to lower rates of preventable hospitalizations. And then lastly, the opportunity to really integrate mental health care with traditional physical health care.
Yeah, and so overall, the main takeaway was that although we have near universal coverage, in Massachusetts, the keyword is near. It's not we have universal coverage. There's still, 2.7 or something % that have no insurance coverage, and many of those people are underinsured or uninsured. So there's still a huge need for something to be done for these people that even if they have insurance, they're not able to access it because of cost. And I hope that answers the question.
I think it does. And for folks who are watching, really appreciate the questions coming in. And we'll be making this video recording available. So because the material that Dr. Hsiao and Sameen and Olivia are sharing is dense, and we will make sure that we have it available so we all can look at it again and again. Professor, we have a question for you, and it wants more detail on the California experiment you talked about. So where in California, who undertook it, what did they find in California, or what are they in the midst of uncovering in California about the single payer system?
In California, the governor, Gavin Newsom, when he ran for the governorship in 2018, he said he would endorse or push for a single payer system for California. So after he assumed, won the election, he appointed, through legislation, appointed a commission to see how California could move forward toward a single payer system. And I happen to be fortunate, got appointed on the commission. And then I work with students at Harvard, like the two bright students you're meeting now, Olivia and Sameen. So two other students decided they want to try experiment, do a survey, and actually see when you give people more information, do they change their minds about their support for a single-payer system? So they actually sampled close to 800 Californians at random. And they found the results, as I reported, that when you tell people now, yes, you might have to pay, you're going to pay higher taxes or payroll contribution, but now you don't have to pay out other ways. That is including your the premium you're paying now, the out-of-pocket costs, the state taxes, local taxes that goes into support healthcare, and all of that will be gone. And actually the savings could be, at least a portion of it, could go back to you as your cash wage. Then they found roughly 5% of the people changed their mind just with that really minimum amount of information done in a survey.
That's very helpful. Thank you so much. I have another question for you. And by the way, I agree with you that Sameen and Olivia are bright lights. They give me a ton of hope. So I share your admiration for them. Doctor, I have another question for you. And this is actually at the intersection of your comments around Medicare for All, starting with universal coverage. The questioner wants to understand that better. What precisely do you mean by universal coverage? And wonders whether or not that means that everybody would have a private health insurance policy. So a bit more texture there is being asked for via Facebook.
The universal health coverage usually means it's universal, that is everyone will be covered. And so single payer system is is one type of universal health coverage. To achieve everyone being covered, then whether there's a role for private insurance, that depends on how you design the benefit package. Under Senator Bernie Sanders' proposal, the Medicare for All covers everything. So it leaves virtually no room for private insurance. However, let's say if the patients, let's say if long-term care is not covered, right away that will leave the long-term care to the private insurance industry. Let's say cosmetic surgery is not covered, that will leave for the private insurance industry. So if you want to think about it, it's like under Medicare doesn't cover everything. Medicare actually only cover 55, 60% of total healthcare costs for the elderly. So consequently, the patients still have to pay the other 40%. That's why you have the Medigap insurance. So the same principle can be applied to universal health coverage. Universal coverage means everyone is covered and covered with the same benefits. But what's that level of benefit that requires a social compact between the people and through the legislators to say, we're willing to pay this much for that amount of benefits. And that amount of benefit covered would determine what role it leaves to the private. Then just for your information, in the world, most countries leave roughly, initially leave about 10% of the healthcare for the private industry.
Thank you. That was incredibly helpful. This is another question for you, Professor, a little bit in the weeds, but I think important. Does the HRSA require standard cost accounting by the hospitals?
Yes, the current Medicare program requires the hospitals to follow the standard accounting principles, and their financial statements have to be certified. But there's no requirement on cost accounting. Here we're talking about you use your accounting system, your bookkeeping system, produce, really allocate the cost down to each procedure to see how much really that costs. And that methodology has been developed and standardized for about 20 years, 25 years now. But we don't require the hospital to do it. They probably do it privately, but they will not make their information public.
And that's one of the things that we have to rub up against or push on in terms of policy. Professor, I really appreciate you calling us out in terms of the legislature. I'm sure Senator Eldridge does as well. I know that he is certainly the Senate filer of the Medicare for All bill. Representative Sabadosa is the House filer. And then, as you know, sir, there are many co-sponsors. I'm proud to be one of them on the legislation. And I do think there is a role at the state level to push on this in a lot of different ways, including that legislation, and certainly importantly with regard to that legislation. So I just want to, as we reach nearly the 5:15 mark, I want to make sure that you all have time to offer any additional or closing thoughts. And again, I'll say to the folks who are watching, we're not going to be able to get to all the questions. We're glad you're so engaged, and certainly we'll make this video available. So Professor Sameen or Olivia, do you have any closing words that you'd like to offer?
Sure, I'll start and just say, once again, thank you, especially to Professor Hsiao, to Sameen, and to Senator Comerford, as well as to the staff in Senator Comerford's office, who are complete rock stars. One of the aspects of doing this project that I would love to share is there really is a wealth of research on health systems around the world. And there's so much for the United States and for Massachusetts to learn in the realm of public health and health systems. And so really what Sameen and I started the presentation with, talking about, the political rhetoric that surrounds this topic. As with many other things in our country, it would be lovely to move away from that and really move towards what Professor Hsiao mentioned, and really looking at the data and the evidence, because what this all is about is making our populations more healthy. And so I'd really encourage everyone who's watching to think very critically about lessons to be learned throughout the world in health systems and in public health.
Thanks, Olivia. And I want to say that I agree with you that the team is amazing, and just I'm sure we're all wanting to shout out to Brian Rossman, who's the legislative director. I see the clapping.
Most
and
definitely.
he is our team poet and visionary. So and really believes in this with all his heart, and has led us on in it so beautifully. Any other closing remarks? Dr. Hsiao or Sameen?
Sameen, or you want go first or me?
I can't go before you, Professor Hsiao.
Well, I compliment you, Senator, that you engaged these very capable young women and pursuing something really beneficial and interesting for the Massachusetts. My word is that I'm really hopeful and optimistic that Medicare for all will be a reality for two reasons. Healthcare costs continue to, even in Massachusetts, continue to rise faster than the wage rate increases. And it's really, it imposes such a pressure on the state and local government budgets, as well as companies, including Harvard University. And so we have to somehow bring our costs down from that everyone paying $11,000 on average for healthcare down to something more affordable. Second, I found actually the other encouraging sign is physicians are changing their views. And in my work around the world, I have now found a country that can make a major change without the physicians agree to it. And right now, roughly 47% of physicians actually believe Medicare for all or single payer system is what we need. That's why I'm optimistic. So keep up your good work, Senator, and your colleagues.
Well, we're all linking arms together, Professor, including with you through this panel. Sameen, do you want the last word?
Really, there's nothing I can add, which two incredible comments here with Professor Hsiao and Olivia. So all I can say is I wholeheartedly agree with both of them, and just a heartfelt thanks to everyone in the whole team for all the amazing work that's been done on this project. So thank you.
Thank you. Beautifully said. So in closing, friends, I want to shout out to Afnan especially, and Team Eldridge, Sam, and our team, the Western Mass Medicare for All, MassCare, and the Massachusetts Legislative Medicare for All Caucus, and these esteemed panelists. It's really, really heartening and inspiring to link arms with all of you and all the constituents who care deeply about this. I fight for this personally because my constituents care about it, and they hold me accountable, which is the best part of being an elected official, getting to do this work. So friends, we're going to sign off and take good care. Thank you so much for tuning in. Bye-bye now.
Bye-bye. Thank you.